So I'd like to introduce Dr. Mark Walsh. He's the chair of the scientific committee for the National Pancreas Conference. He's also the chair of the Canadian Association of General Surgeons. And welcome, Mark.
Thank you, Stephanie. And welcome everybody to the National Pancreatic Conference. It's the first one we're having. CAGS has helped working on this. So all of you who need to get your MoComp points, this is the way to do it. It will be very informative, and I'm looking forward to the next couple of days. This particular topic, disparities in healthcare, is of particular interest in Canada right now. Certainly, there's been concerns around provision of healthcare to poorly represented groups of people, different ethnicities and races, and whether or not they're getting equal access. And I think it's a very important topic to discuss. And so it gives me great pleasure to welcome Dr. Marcus Smith-Noel, who's a medical oncologist at the MedStar Georgetown University Hospital, where he's also associate professor of medicine in the Department of Medicine and also director of clinical research management at the Lombardi Comprehensive Cancer Center. It's there that he's also a co-PI of an NCORP grant at Lombardi and is also investigator for the Alliance Cooperative Group. His research interests are addressing health cancer care disparities amongst patients in the U.S. There's really, as I said, been several reports of bias in how we provide healthcare. And so we're really looking forward to Dr. Noel discussing his research and as to how we can better things here. Thank you, Dr. Noel.
Thank you, Dr. Walsh, for that kind introduction. Thank you to Stephanie and the organizers of this meeting. I'm really honored to be able to present to you today. Okay. All right, so here are my disclosures. So what I'd like to do today is give some definitions, go over definitions on health disparities, on race, and then we'll go into some of the history of racial discrimination, at least from the medical standpoint in the US, review cancer statistics, and then kind of look at some current disparities. And then I brought in some work that's been done in Canada, which will be applicable to this group, but I really think that many of these principles do apply in Canada as well. And then would like to conclude with looking at potential solutions. And, I think it's important that we discuss these issues, but it's also key to look forward to think about how we can begin to address these disparities and equal care for all patients who suffer from this devastating disease. So let's get started. So what is a health disparity? It's a particular type of health difference that is closely linked with economic, social, or environmental disadvantage. Health disparities adversely affect groups of people who have systemically experienced greater social or economic obstacles to health based on their race or ethnic group, religion, socioeconomic status, gender, age, or mental health, cognitive, sensory, or physical disability, sexual orientation or gender, geographic location, or other characteristics historically linked to discrimination or exclusion. So it's a term encompassing a number of different factors that can lead to potential discrimination. Racial disparities in healthcare are well documented. It's been established that racial and ethnic minorities receive a lower quality of healthcare, even when income and access are accounted for, and disparities exist through multiple sectors of the healthcare system. So race is a term that can sometimes be misused or a bit confusing. It's a poor proxy for industry. So industry is really linked to genetics. In regards to health disparities in African Americans, without a true discussion of the impact of institutional inequities and other social political ramifications, it's easy to confound variables. And to search for biological differences between the races the search for biological differences between the races to explain disparities will continue. And I think that it's important that sometimes it's often convenient to focus on biologic differences, but there are a number of other factors that lead to disparities in healthcare for typically underrepresented populations. So this is kind of going back a little bit into at least US history in terms of practices that were utilized back 100 plus years ago. Some of the early medical schools actually relied on Black bodies as anatomical materials. So there are reports of they would actually go to local cemeteries and kind of steal bodies and then bring them to the lab to use for anatomical dissection. At the time, feeling that certain groups were inferior to others, and so that it was not necessarily a wrong thing to use bodies for that purposes. And then later on in the 1930s, 40s, there was forced sterilizations where not only for underrepresented minorities, but for those who were maybe mentally ill or had other disabilities, where there were forced sterilizations to without consent to try to prevent reproduction. In the U.S., these are two examples that are, I think, two key early examples that, in my opinion, and the opinion of many others, have led to mistrust, certainly in the U.S. healthcare system, but I think pervasive even outside of the U.S. The Tuskegee study, to briefly summarize, was a study where over 500 poor sharecroppers, African-American male sharecroppers, were enrolled in a study where they were told they were going to be analyzed for bad blood, and they were told they were going to be given medical care and medicine and other resources to help understand what this bad blood was. In actuality, this is a study on syphilis, and so these patients enrolled had syphilis, and initially at the time there was no cure, but into the 1940s, when penicillin was developed, then we had a cure, and but the participants in the study were not made aware of this. They didn't understand the disease they had, and then when there was treatment available for this, they were not offered this treatment. And it was kind of a study to look at the natural history of syphilis and untreated for what was quoted the Negro male. And so this led to syphilis untreated can lead to significant health disturbances, including mental health and even death. And so a number of the participants were eventually became ill from disease and passed away. And this study went on for decades. And it wasn't until I think into the 1970s when the authorities were alerted and this was shut down. But this went on for so long, and so this is an example of at least the U.S. government utilizing Black subjects as research subjects and not treating them as equal citizens. And so this is something that is, and especially for older African Americans, it's been something that is still affecting them today. Second example is Henrietta Lacks, who was a young Black female in her 30s who was diagnosed with an aggressive gynec cancer, and she presented to Johns Hopkins, and she ultimately had a very, very aggressive tumor that was growing rapidly, and her cells were harvested without her consent, and then those cells were used for research. And the key here is that she did not consent for this. Interestingly, after she passed away, the cells were continued to be utilized for research. They're actually nicknamed HeLa cells for her first and last name. And there's been tremendous work that has been done with her cells in terms of research. But the premise again was that she was not consented on this. And so this goes back to informed consent, and when conducting research, not informing the subjects of what you're doing. But this has actually had a positive spin, because now Hopkins has annual events where they bring in local, the community of Baltimore is there's a large African American community in Baltimore, and young kids will come in and learn about the history of Henrietta Lacks and how her cells have led to a number of research breakthroughs and vaccines, et cetera. And the family has embraced this as a positive role, and she actually now is recognized as an important woman in science due to the use of her cells. So this is a quote from the former U.S. Surgeon General, Jocelyn Elders. "Health is more than an absence of disease. It's about economics, education, environment, empowerment, and community. The health and the well-being of people is critically dependent upon the health system that serves them. It must provide the best possible health with the least disparities and respond equally well to everyone." So let's shift gears and review some cancer statistics. So this is not a surprise to this group. Pancreatic cancer is a disease with a very high death rate. Actually, in the U.S., it's going to be the #2 cause of cancer death behind lung cancer, surpassing breast cancer. Breast cancer deservedly so gets much attention, but I think we probably should do a better job of educating the community on pancreatic cancer. In Canada, in 2020, it was estimated that 6,000 Canadians would be diagnosed with pancreatic cancer. And unfortunately, over 5,000 were expected to die from pancreatic cancer. And in 2021, predicted to be the 3rd leading cause of cancer death. These are trends from 1975 to 2017. We can see here disparities between Black and white males and Black and white females with regards to cancer incidence. We can see, at least for the males, rates coming down, but still disproportionate between the races. And again, here we can see disproportionate figures between Black and white males and Black and white females. These are 5-year survival rates, and so we can see on the right column absolute differences, pointing out, particularly in some of the GI cancers, the colorectal cancer, esophageal cancer, absolute differences between survival between white and Black patients. So let's shift gears and review some data in Canada. So this first study was looking at rates of cancer, specialized cancer consultation and cancer-directed therapy for non-curable pancreatic adenocarcinoma. So this was an analysis that was conducted from 2005 through 2016. The primary outcome was specialized cancer consultation and receipt of cancer-directed therapy. This analysis included over 10,000 patients. And amongst the entire cohort, 65% had a consultation with a specialist. And I believe this was defined as either a medical oncologist, a radiation oncologist, or a surgical oncologist. And then 38% received cancer-directed therapy. I'll point out, and the authors pointed out, that only 65% of patients had a consultation with a specialist. And so in a disease where, and I didn't review the treatment data, but for advanced pancreatic cancer, FOLFIRINOX and Gem/nab-paclitaxel are standard of care for a first-line therapy, and they're both associated with an improvement in overall survival. And so, although we still have a long way to go in improving outcome in pancreatic cancer, we do have chemo that is marginally effective. And so one would hope that there would be even higher rates of consultation for patients who are diagnosed with pancreatic cancer. In this study, socioeconomic status was not associated with likelihood of medical oncology consultation. Older age and lower income quintile were associated with lower likelihood of receiving cancer-directed therapy. And this is I don't expect you to necessarily be able to read this entire chart, but I'll point out that the older age, not surprisingly, age over than 81 had lower rates of consultation with medical oncology. But what I also will point out is that the lowest income quintile was associated with lower rates of med-onc consultation. So definitely a difference here based on income. A second study looked at cancer resection rates and socioeconomic deprivation and geographic access to surgery among urban, suburban, and rural populations across Canada. So we know that there's fairly good data stating that, particularly in GI cancers, pancreatic cancer, these difficult operations are often, outcomes are better in the hands of more experienced surgeons, where there are higher rates of more experienced surgeons where high volume centers, and so complications are often minimal when you're at a high volume center compared to smaller hospitals. So this study looked at 5 cancers with high risk surgeries, including pancreatic cancer. It excluded Quebec, and again analyzed socioeconomic trends in resection rates. And what the study found is that travel times to treatment were consistently higher amongst the most socioeconomic deprived patients, most notably in rural areas. And so here we're looking at pancreatic cancer. So the study broke down urban, suburban, and rural. And so in pancreatic cancer, rates of resection actually were lower in the urban setting versus suburban and rural. Excuse me, this was true for all sites. Now the authors hypothesized in this study that in some other studies, they combine urban and suburban kind of as one unit. And so separating out the suburban category, that was actually closer to rural versus urban, where there were lower rates of resection in the urban population in this particular study. And looking at socioeconomic quintiles, so 1 being the highest, and then 5 being the lowest socioeconomic status. So you can see that in quintile 5, there were lower rates of resection for not only pancreatic cancer, but in all 5 of the cancer studied in this study. In this particular study, the hypothesis regarding the highest quintile is that this is a group where there are lower rates of cancer. So certainly a disparity here based on socioeconomic status. A third study looked at the impact of geography on care delivery. This was a retrospective analysis of non-curable pancreatic cancer from 2004 to 2017. This was conducted in Ontario. Exposure was distance from resident to nearest center providing med-onc care. And the outcomes were medical oncology consultation, receipt of therapy, and overall survival. So out of greater than 15,000 patients, 65% received a medical oncology consultation, 38% received systemic therapy. The mapping in the study revealed regional discordances between outcomes. And so the study broke down the distance. This is in, so I believe it was There were three different groups. Greater than 100 kilometers was the greatest distance, 50 to 100 kilometers was the middle distance, and less than 50 kilometers was the lowest distance. And so these are the hazard ratios, 0.978 and 0.77. So this represents the longest distance with so the longer the distance, the lower likelihood of receiving med-onc consultation. And then for survival, this represents the longest distance, 1.10. This is the shortest distance. So we can see some differences there that was pointed out in this study. And again, patients with advanced pancreatic cancer from 2008 to 15 were reviewed. This is across British Columbia. Actually, I'm sorry, let me go back to this slide, and then that's an error, but this is the slide that I wanted to present. So looking at the smaller distances, you can see that there are, the longer the distance, the lower rate that you see of med-onc consultation. And so another disparity here. And again, use of cancer-directed therapy, the longer the distance, the lower the rates that you see for cancer-directed therapy. Shifting gears back to the US, this was a review that I did several years ago, just looking at pancreatic care disparities. So in one study, it was reported that surgical resection was offered more frequently to white patients compared to non-white patients. That was significant. Resection at high volume hospitals. So this is defined as greater than 50 Whipple resections in a year. So resection at high volume centers was more likely in white patients compared to non-white patients. African Americans were less likely to receive chemotherapy compared to non-Hispanic white patients. That was significant in that particular study. And then African Americans were more likely to refuse surgery. And this may be linked to issues of potentially mistrust or skepticism of the healthcare system, which we'll talk more about. So pancreatic cancer is a disease where, given the overall poor outcomes, clinical trial participation is critical in order to advance the field and develop better options for treatment. This was a retrospective study that was done from 2004 through 2016 using the National Cancer Database. The cohorts were stratified by enrollment on trial for the first treatment. And so this looked at hundreds of thousands of patients, and only 1,000 patients were actually enrolled onto a clinical trial, so 0.4%. So certainly much work that needs to be done there to have higher rates of enrollment across the board. During the period of the study, enrollment increased, but did not increase for Black patients or patients on Medicaid. And on multivariate analysis, the non-white race and Medicaid or lack of insurance were predictors of lack of participation in clinical trials. And so here you can see the rates increasing overall for all of the subjects, but when you look specifically at Black patients and Medicaid patients, we don't see that significant increase in clinical trial participation. So this is a study that was done in the Journal of Clinical Oncology, looking at disparities in stage at diagnosis, treatment, and survival in non-elderly adult patients with cancer. And this looked at a number of different cancers and really looked at insurance status. Looking at 10 of the most deadly cancers using the SEER database. You can see here, so the top curve is the non-Medicaid insurance, and then the bottom two curves are the uninsured and the Medicaid equivalent. And we can see here a difference based on insurance. And so the cancer-specific survival, the cause-specific survival was higher in those with non-Medicaid insurance. And here we can see outcomes for cancer. And so this is looking at, again, 10 different cancers. We can see liver cancer, pancreas cancer, esophageal cancer, colorectal cancer, so a number of different GI cancers. And having Medicaid or being uninsured was associated with worse outcomes. And these were significant, not crossing one. We can see here for pancreatic cancer. So I conducted a project at my previous institution looking at disparities in pancreatic cancer. This project was I kind of initiated based on my experience in clinic, where I often saw that my patients who were either underinsured or Hispanic, African American, it seemed like they always were coming in with either more advanced disease or just it took them a longer time to get in for their evaluations. And so my question was, is there a delay from the time of symptom onset to presentation to medical oncology or oncology in general based on socioeconomic status? And what I did was to stratify patients based on insurance status, so the Medicaid or Medicaid equivalent versus private insurance. So this is a small study, but looking at a total of about 80 patients. And here are the different characteristics of the patient population. The key here at the bottom is that in the patients who had private insurance, the median diagnostic delay. So this was defined as we went back into the charts and looked at when they initially had their symptom onset, whether it be jaundice or when the patient first reported pain or weight loss, to the time at which they were evaluated by a cancer specialist, whether it be MedOnc, SurgOnc, or RadOnc. So the average time was about 10 weeks in the private insurance group, but in the Medicaid equivalent group, it was 19 weeks. And there was a significant difference there, almost doubling of the time to get in. And so I think this is important because, and I think this bears out in larger studies where there is a delay in getting in for care. And we can talk about this in terms of different aspects of the healthcare system that lead to these delays. It can be argued that does this delay impact overall survival? In a disease in pancreatic cancer, where survival is overall poor, it may not bear out a survival difference, but patients who are delayed in coming in for their care may not be able to receive chemotherapy as effectively. And so quality of life could be impacted by being more symptomatic from the disease for a longer period of time. So I'd like to just step back and reflect a little bit as a Black medical oncologist and kind of share my experience a bit. So at least in the United States, I think that the demographics of many of our cities cannot be ignored. There is often some of the best teaching hospitals and the best care may not be easily accessible to certain groups of patients. For example, even here in Washington, D.C., where I work at Georgetown University Hospital, Georgetown itself is a very affluent area. And so the surrounding neighborhoods of Georgetown, there are lower rates of Hispanic African American patients in the areas of the city of DC where there are higher rates, higher population, higher numbers of African American patients. The access to Georgetown is limited. So public transportation, there's not a direct stop on the metro line at Georgetown. And so it's harder, more difficult to travel in for appointments. And so that can impact one's ability to receive care at a specialized center. impact ability to go into clinical trials. In Rochester, where I previously lived, the area of the city where the teaching hospital was further away, and there was often still a mistrust where patients would not come in to the university hospital because they were afraid of being used as research subjects, afraid that they may be viewed as almost second-class citizens. And this goes back to some of the early studies that I mentioned with Tuskegee, where there's mistrust that is prevalent. And then with regards to the healthcare system, it's often hard to navigate. This may be not as much a case in Canada, where there's universal healthcare, but it can be difficult to get in to see a gastroenterologist for workup and diagnosis of cancer, to then get in to see a specialized oncologist. And so these delays can sometimes be mitigated if you have better insurance, or if you're more affluent and have connections to get through the healthcare system. If you're uneducated or just don't have the resources, it can be more difficult to navigate through the healthcare system. And so this can often lead to disparities in initial receipt of cancer care, and in some diseases, actually cancer outcome. So how do we move the field forward? What can we do to address these disparities, these healthcare disparities that I've reviewed? This is a study that looked at cost effectiveness of leveraging social determinants of health to improve outcomes in breast, cervical, and colorectal cancer screening. This is a systematic review. So cost and incremental cost effectiveness of interventions targeting social determinants of health to improve cancer screening. So patterns observed in intervention costs and incremental cost effectiveness of public health interventions aligning several domains of social determinants of health to improve cancer screening. So are there interventions that we can do to leverage social determinants of health to improve cancer screening costs? Can we perhaps utilize language services, provide education materials, provide rides, vouchers, et cetera, to improve cancer screening? So the study looked at the median cost for interventions, and the median cost was $123. Specifically for colorectal screening, the intervention was $46. The median incremental cost per additional screen for all interventions was $250. Specifically for colon cancer, it was only $110. The median incremental cost per quality of life adjusted year was over $3,000, but the median incremental cost per quality of life for colorectal cancer screening was actually negative. So putting money into the system, putting money into these interventions actually saved the system money in terms of rates of colorectal cancer screening. And so I think the take-home message here is that at least in a disease where we have adequate screening, we can use resources to try to mitigate differences in socioeconomic status to increase cancer screening outcomes. In pancreatic cancer, where screening is not yet available, we may not be able to leverage this, but at least in colorectal cancer, this is something that can definitely be further explored. So other ways to move the field forward: we need boots on the ground. We need to get out into the community and provide education for our patients. So prior to the pandemic, I often would speak at local churches and health fairs, educating patients on symptoms of pancreatic cancer. Actually had a virtual conference earlier this morning, speaking at a local church here in the DC area, providing education on pancreatic cancer to educate the consumer, the patient, so that they can be aware of what to look out for should they be unfortunate to be diagnosed with pancreatic cancer. I think we need to provide education to our providers. There is certainly some unconscious bias that may exist in terms of how we view patients, how we treat patients. Again, this is not necessarily that we are racist, but that we may view patients in a different way based on how they look, based on where they come from. And so it's important that we understand that these biases exist so that we can make a change. I think it's important that as we also educate our youth, that we offer programs to the youth so that we can increase the number of underrepresented minorities who ultimately choose a career in healthcare, whether it's nursing, physicians, whatever it may be. It's important that the workforce mirrors that of the general population. So, in conclusion, healthcare disparities extend back for decades and even centuries. Rates of screening and death remain disproportionately high in minority populations. Socioeconomic status plays a large role in this. Shifting gears to Canada, even though we may not see some of the racial disparities, I didn't present those today. There certainly are disparities with regards to socioeconomic status as well as distance in terms of coming in for medical oncology consultation and cancer-specific care. I believe that trust is and does remain an issue, and we're seeing that even during the pandemic with lack of trust in the vaccine, lack of trust in following public health guidelines, and some of this stems back to some of the early discrimination. In order to move the field forward, I think that we need community engagement. We need to be able to educate the population on cancer, particularly pancreatic cancer. And we need to potentially also utilize different tools with regards to social determinants of health to better support those patients who otherwise have limited access to healthcare. Again, I'd like to thank the organizers of this meeting for allowing me to speak today. I'm honored to be able to share with you briefly this morning, and thank you once again.